our contact with the environment is through some sensory organs. We see through our eyes, we hear through our ears, and we have a perception in our skin, temperature, touch we can perceive, and also we have a joint position sense, so that you can stand erect and we know when I am lying, when I am standing, what I am doing, that everything that joints and position sense. And there are vibration sense also. So these things have to be learned from the very birth. A child, 1 year old, he learns how to stand. So it is a learning. Standing, you're cycling, you're swimming, these are the process of learning. You learn it, and you have the skilled movements, and also you memorize it, so that you can repeat it in your future life. When it comes in the cycling, you can do cycling because you have already learned and you have memorized that in your brain. A child has learned how to stand. He has memorized in the brain, he can stand upward in his life, unless he is affected by some disease. That child at the grown up age or in the old age may even forget how to stand. Because that memory is lost, how to stand. We call it ataxia. The patient's ataxia. The patient cannot stand erect. He tends to fall. That is, he has forget the process of learning of how to stand. So these are the very important systems. So with this introduction, we are going to describe the sensory system of the body. Sensory systems is I have already told you, is the contact with your environment. You learn and you memorize. So this sensory system, that if your spinal cord, there are some tracts which are going upwards. They are carrying your sensations. These different modalities of sensations I have already told. They are carrying it through the spinal cord from your skin, eyes, ears. They are carrying the fibers through the spinal cord to the higher center of the brain. Usually the sensory system in the thalamus. The thalamus is also projected to the cortex. These are the modalities of sensations carried through different tracts. Different modalities of sensations they are carrying through the spinal cord in the different parts of the brain, particularly in the thalamus, through this spinal cord. So these are ascending tracts. This thalamus projected to the cortex, sensory cortex, they gives the inputs to the sensory cortex, then sensory cortex sends the input to the motor cortex. Then motor cortex starts functioning. They function through the descending tract because they are sending their signals to the descending tract. I have heard about the corticospinal tract, and there are some other pyramid. This is a corticospinal tract, is a pyramidal system. There are some extrapyramidal system also, that they are nuclei in the brainstem and others. So these are descending tracts. These descending tracts are responsible for motor activity. Not only visual motor activity, it should be very coordinated motor activity. What you want to do, you can do it in a perfect way. That is a coordinated motor activity. So first we will discuss the sensory tract, then we will try to discuss the motor tracts. Then if the time permits, we will also discuss about what are the diseases associated with this disease with the sensory tract and motor tracts they are affected. That if time permits, we will discuss that also. So to start with, we are going first the ascending tracts, which carry sensations from the periphery to our brain, central nervous system. So you know that what is the region, the cutaneous sensation like pain, crude touch and temperature. So different modalities of sensations are carried by the different tracts. There are different names of the tracts, and when the disease will affect the spinal cord, then these tracts are also affected according to their positions. Naturally, if the trauma is from the outside, or from tumors pressing it from the outside, or a tuberculosis of the spine which is pressing from the outside of the spinal cord, will affect the tracts which are at the periphery, at the contact with the vertebral column and the spinal and the periphery. But when a tumor or some spinal canal is in the center, that is enlarged, then definitely the tracts which are close to the center, that will affect it first. So disease will be described according to the disease. Different tracts will be different ways. So you will have to learn this. What diseases, which tract affected first. When you are going to examine the patient, then you will see which tract is affected first. That will give you an idea that where the tumor, where the compression is. So where? So it is a cutaneous tract. There is a cutaneous sensation. We know that's pain, crude touch, and temperature. It is not fine touch. Fine touch is a different. Crude touch and fine touch are different pathway. Crude touch, fine touch we examine by just rolling a cotton, a piece of cotton. You just roll over the skin. That is called a fine touch. But as a crude touch, if you take the head of a pin and press it in the skin, that is the patient can feel that pin is there. So that's the way how the crude touch is examined. Fine touch by cotton and crude touch by your pin head. So this the pain, touch, and this temperature are carried by the lateral spinothalamic tract. There are spinothalamic tract. I have already told you they are carrying the sensation from the skin through the spinal cord. They go ultimately projected into the thalamus. Thalamus also don't take the final decision. Final decision will take by the cortex. Thalamus will project it into the sensory cortex. But their temporary relay station of the all sensory modalities are in the thalamus. So this goes to the thalamus, the opposite side, from the opposite side. You know that always in the neurology there is a dictum, there is a rule followed by the nerves that a second order neuron always cross to the opposite side. You know that we have a posterior horn cell, posterior neuron. No, there is a posterior limb. There is a posterior neuron. The relay station is the posterior. This pain temperature from your cutaneous nerve. Suppose it is the ulnar nerve, it will go to the ulnar nerve and it will go to the this C8 segment. You know the ulnar nerve. Each nerve has got their own segments from where they come out. So this C8 or they enter. This ulnar nerve, they will carry your sensation from this side, goes to the C8 and T1 level, C8 and T1 spinal cord level, not vertebral level, because vertebral level and spinal cord level do not match. That will come later. So there is spinal cord level. So always when we are telling a level of the level, always tell is a spinal level or a vertebral level, because they do not match. You know that the spinal cord is ended at the lower part of the L1. That the spinal cord ends. So all the spinal cord segments has to be end that L1. So if there is a lesion in the L1, suppose the vertebra compressed to the level of the L1, that doesn't mean that L1 segment is affected. That is the S5, the end of the S5 has ended in L1 because the spinal cord ends there. All segments are accommodated within this L1, but vertebral column continues up to the S5. So the spinal column, spinal segments and the vertebral segments do not match. So try to understand it. So anyway, what we were discussing about all this spinal level, not vertebral level, spinal levels. So lateral spinal from C8 T1 they carry the fibers to the C8 and T1 level. At the posterior horn, posterior root, there is a relay station, the posterior horn cell. So that is the relay there, and the second order neuron will cross to the opposite side. Second order neuron always cross. So spinothalamic tract from the through the posterior root, they will enter and they will cross. They will cross to the opposite side and produce a spinothalamic tract in the spinal cord in the opposite side. So your left hand, the spinothalamic segment will be in the right side of the spinal cord. So this way, these get carried to the opposite side, and they are projected to the ventral posterior lateral and ventral posterior medial nucleus of the thalamus respectively. So body temperature lateral that and opposite side of the body. These kinesthetic sensations. These are the nucleus where the spinothalamic will ultimately be projected. And another mode of sensation is a kinesthetic sensation. Kinesthetic sensation is a joint sense. I have told you, joint sense, vibrations, and sense of posture. Sense of posture. These are the different modalities of sensations. And pressure and fine touch, they passes to the posterior column by the tract of Gracilis. They are called the tract of Gracilis medially and tract of Cuneatus laterally, carrying the fibers of the lower limb below the T6 and the upper limb T6 above the level of the T6 respectively. So this tract of Gracilis is medially and tract of Cuneatus laterally. Tract of Gracilis they carrying the fibers of the lower limb below T6, and the tract of Cuneatus they carries the fibers from the upper limb and above the T6 level. This produces a posterior column in the spinal cord. Anterior spinothalamic tract, there are small fibers anterior spinothalamic tract that carries the crude touch and light and pressure touch. This is anterior spinothalamic tract, usually do not cross, they cross above. Anyway, but spinocerebellar tract, another important tract is this. These are all ascending tracts. Not I will discuss the descending tracts or motor tracts separately. Spinocerebellar tract, the anterior and posterior spinocerebellar tract. What they take fibers from the different through the nerves, peripheral nerves, the fibers enters the spinal cord and they ascends upwards through the spinocerebellar tract and ultimately ends in the, as the name suggests, they ends in the cerebellum. You know that cerebellum is attached to the brain stem by some cerebellar peduncle. So through the cerebellar peduncle in the brain stem, after leaving the spinal cord, they will leave this, and through the cerebellar peduncle they will reach to the cerebellum. So what they do, they are responsible for unconscious perceptions. Unconscious perceptions means when you are not aware of, you have the perceptions still on, from muscles, tendons and joints to the cerebellum for coordination of posture and movement. These are the different ascending tracts. We will come to the picture how these ascending tracts act. Now, you know that this, we have already told you the tracts through is the modalities of sensations are passing through the spinal cord and reaching the brain. But this segment, the body is divided into 31 segments. These are all called dermatomes. These are called dermatomes. Each dermatome has a posterior root and an anterior root to enter the spinal cord. So, they enters through the spinal cord. There is through the posterior root. So, there are 31 segments of the spinal cord, which will be the pair of ventral and dorsal and innervate motor and sensory functions respectively. So, anterior horn cell, the anterior and posterior nerve roots combines each other to form the spinal nerve as they exit the spinal canal. So, when they exit through the posterior root, I have told you actually it is not the sensory nerves are entering through the posterior root, and the anterior root, the motor nerves are coming, they meet together and forms a nerve. So, each peripheral nerve has a sensory component and motor component also. I have given the example of ulnar nerve. The ulnar nerve has a sensory component and motor component also, but it has gathered it from the different segments. So, suppose ulnar nerve, I have told you C81. They have gathered it from this dermatome of C81. Sensory, they are passing sensory from the C81, and they are also giving motor supply to the muscles, which is supplied by these C81 segments. So, the nerve is a composite things. So, 31 spinal segments each are giving rise to 31 spinal nerves. You know, there are 8 cervical, 12 thoracic, 5 lumbar and 5 sacral and 1 caudal spinal nerves. Dermatomes exist for each of the spinal nerves except C1. The C1 segment, they have no dermatome. Sensory information from specific dermatomes is transmitted by the sensory nerve fibers to the spinal nerve and specific segment of the spinal cord, that I have already. Dermatomes along with the arms and legs differs from the pattern of the trunk dermatomes because they run longitudinally along the limbs. Now, these are the you will see these pictures in many your books, that these are the distribution of the dermatomes in 31 dermatomes. This conception of dermatomes are important because several diseases are spread through these dermatomes. Suppose, I am giving one example. There are several, but I am giving one example. Suppose there is a patient is suffering from a herpes zoster. You know that herpes zoster is a chickenpox virus. But somebody suffers from chickenpox, have their manifestation of chickenpox, skin rashes and everything. But somebody has got the immunity. They have the virus, but they do not suffer from chickenpox. And they have the sound immunity. Because of this sound immunity, because of this sound immunity, they do not suffer from chickenpox. But that virus, varicella zoster virus that is causing chickenpox, they enter into the posterior root and they remains there in the posterior root. Because of the immunity, they could not come out, produce the disease. But they remains in the posterior root is their home to stay. They stay. They can stay for several years, 10 years, 12 years, 20 years, 30 years. The virus will stay in the posterior root. But when there is a breach in the immunity, suppose the patient is suffering from diabetes. Diabetes is also immune suppressed state, or some immune suppressions. You are giving a corticosteroid drugs. That is immune suppression you are doing, corticosteroid drugs. For some reason, the patient started taking corticosteroid drugs, or some monoclonal antibodies patient start taking. Then when there is breach in immunity, that posterior root, the virus stays in the posterior root, then they come out of that posterior root. So when the virus will come out to the posterior root, they will definitely follow one dermatome. So herpes zoster, the vesicles will follow one dermatome. That's why this conception is important. Suppose in the herpes zoster you get some vesicles you get in the level of the, I think it is suppose you get a level of the C4. Suppose you get some vesicles in the level of the C4. Then you that C4 supplies the right collar, below the right collarbone or left collarbone. If it is in the right side, the virus stays in the right side, then the right side below that collarbone, the vesicles will be appear. And there will be no vesicles below that or above that. Usually, it follows one dermatome. But exceptions are there. If the in a HIV patient, of course, several dermatomes may be affected at a time. But usually, varicella zoster virus, one dermatome. So this is giving you example of one disease. There are several diseases which follows one dermatome. So conception of this dermatome is important. Now in these pictures, you know that you have seen in these pictures, these the blue color tracts I have already described. These are the ascending tracts. These are the ascending tracts, and this anterior root and posterior root. Ascending tracts, you know, there is and this anterior spinothalamic tract is there. This is lateral spinothalamic tract. It is written contralateral because it has already crossed. So lateral spinothalamic tract, it is a lateral spinothalamic tract is carrying what modalities of sensation: pain, touch, crude touch, and temperature. Sensation carrying, they cross the opposite and produces this lateral spinothalamic tract. And this anterior spinothalamic, they also carry some crude touch. Anterior spinothalamic, they also carry some crude touch. This spinocerebellar tract I have already described. There is anterior spinocerebellar and there is posterior spinocerebellar tract. This one. This carries the fibers of posture and vibration position sense. They are carrying also to the cerebellum. Main fibers of vibration position sense, they are carried out by the posterior column. This is called posterior column. And this is a fasciculus cuneatus. This is carrying the fibers from the upper limb above T6 level. The lower limb at the upper limb at the T6 level, and also the fasciculus cuneatus, they carries the fibers from the lower limb at T6 level. They do not cross. You see, this fasciculus cuneatus and fasciculus gracilis, they carrying the posterior column fiber. They carrying the sensor of vibration, position sensor. I have told you, they carrying the fibers. They do not cross. They cross at the level of the medulla. In the level of the medulla, there is a nucleus called nucleus fasciculatus and nucleus gracilis. They will release there, and their second order neuron is actually in the nucleus fasciculatus and nucleus gracilis. They will cross. Every sensory modalities will cross, but at different level. Spinothalamic has crossed at the spinal level, and the fasciculus gracilis and cuneatus, they cross at the level of the medulla. There is a nucleus called nucleus fasciculus and nucleus gracilis. So these are the ascending sensory tracts. So if there is a lesion, you know, if the lesion compressing, here you know there is an anterior horn cell, no, anterior horn cell here. I will come to the next picture, then I will tell you. So these are the ascending tracts. Now this is just what I have told you, know, that this spinothalamic, they describe the posterior column, the dorsal column with the proprioceptions. They got the body position, vibrations, and fine touch. And this is I have told you that this is the nucleus gracilis and nucleus cuneatus at the level of the lower medulla. They cross here, the posterior column. They do not cross at the level of the spinal cord, at the spinal level. They cross above and they goes to the opposite side. And this, but this the lower limb and upper limb. This these are middle oblongata. This is the first order. The first order neuron I have told you. Second order neuron always they cross. So by rule, second order neuron cross, and third order neuron starts from thalamus and projected to the cortex. In this way, this posterior column is produced. Now, here you see, this is also the same, the spinothalamic tract. dorsal root ganglia. Here the spinothalamic tract carrying pain, touch, and temperature sensation. Then in the dorsal root ganglia they relay. The second order neuron starts. They cross to the opposite side. They have crossed to the opposite side. They have crossed to the opposite side. Then they ascend upwards. Then they joins with the arm fibers. They join. They together. The lower limb fiber and the arm fibers they join together and going upwards. Some fibers coming from reticular activating system, and then they ultimately they projected to the thalamus and goes to the same side because they have already crossed. As they have already crossed, from the thalamus, the cortical side will be projected to the same side because they have already crossed. But probably you have understood this spinothalamic tract and the previous slide, posterior column tract. You have probably have understood these things. So pain. These are pain fibers. Actually, these exceptions is that I have already told you the sensory fibers are going through the ascending and the motor fibers come descending. But one exception is there. There are some pain fibers, descending pain fibers, very small but important for your pain management. Now, pain management is a different subject. Pain management is a different subject nowadays. They have got their under postgraduate course in different universities. So pain management is an important subject. Just have keep an idea. Some pain fibers has got a descending pain pathway. That is called descending pain pathway. The mesencephalon not very important, but have this idea that only pain fibers has got some descending pathway also. And they are depending on neurotransmitter. I will come to the next slide. So here I have already told you the blue colors are ascending pathways. These are the ascending pathways, and the red colors are descending pathways. We will come to the descending pathways later. But see when this whole thing is displaced, when it is placed in a one slide, the spinal cord section, you will see the already the sensory tracts are. You have already learned about the sensory tracts, the red tracts, the descending tracts. We will learn later. The descending tracts are later, but it is seen in how this red and blue, the ascending tracts or descending tracts are displayed in the spinal cord. This, if you see, follow this, the red tracts, the anterior corticospinal tract and lateral this is a corticospinal tract, lateral corticospinal tract, anterior corticospinal tract. Corticospinal tract, you know, they are motor fibers. From the cortex, they are coming downwards. They have crossed in the medulla, at the level of the medulla, they have crossed and goes to the opposite side. So here you see, if you see in the left side, say corticospinal tract, the motor fibers they are controlled by the right side of the head because they have already crossed in the lower of the medulla. So these motor fibers they have already crossed. So these anterior cerebellar tract, posterior cerebellar, there are some extrapyramidal fibers. I have told you the rubrospinal tract. You see there is the. These rubrospinal, these corticospinal tracts are pyramidal tracts, and I have told you the extrapyramidal tracts. These rubrospinal tracts are extrapyramidal tract. These extrapyramidal tracts are also the descending tracts are there. So pain pathways and neurotransmitter. I have told you neurotransmitter is important because of pain management. Now painkillers they are giving, different painkillers we are using, that depends on the neurotransmitter, because painkillers you are giving, they are just blocking the neurotransmitter so that the pain cannot be transmitted and you are getting relief of pain. So these are the neurotransmitter. Peripheral nociceptor for skin and muscle. These are where the peripheral nociceptor actions we are using NSAID. These non-steroidal anti-inflammatory drugs. NSAID, non-steroidal anti-inflammatory drugs like your aspirin, ibuprofen, diclofenac. These are non-steroidal anti-inflammatory drugs. And corticosteroid also, they are steroids. Corticosteroid also. They act on the peripheral nociceptor. Because in the periphery they are nociceptor, they are pain sensitive. At the terminal, is just the extreme terminal pain sensitive fibers ends there, or you can say it starts there from the nociceptor. The primary afferent fibers, there are different fibers. These A delta fibers and C fibers. A delta fibers are fast and they are myelinated fibers. First fibers, and they are C fibers, also called slow fibers, and they are all unmyelinated. So, local anesthetics and opioids acts on these fibers. If we add a local anesthetic, there sometimes we use in a very painful condition, some local anesthetic you use there, they will carry through the A delta fibers and C fibers, the myelinated and non-myelinated fibers. Obviously, the myelinated fibers will they are nodes of Ranvier and the myelinated fibers, and they will jump. So, the nodes of Ranvier, they jump. That is why they are faster. Myelinated fibers, the non-myelinated fibers, they are slower, because they have no myelination and nodes of Ranvier. Anyway, so dorsal horn, in the dorsal horn, I have told you they pain fiber, this enters to the dorsal horn. So, this dorsal horn, the glutamate for fast and substance P for slow pain fibers. I have already told A delta and C. So, this glutamate and for fast and substance P is for slow pain fibers there, because there are drugs acting on this anti-glutamate and substance P. There is nerve fibers. You have to remember this. So, dorsal horn. In thalamus, thalamus, there is glutamate and dopamine facilitated also. So, usually in the nervous system, this glutamate and this GABA butyric acid and glutamine, they are usually these inhibitory fibers, and dopamine can act as an inhibitory and stimulatory also, depending on the receptor site. So, descending pathway, there is a periaqueductal grey matter. Periaqueductal grey matters I have already shown is there is a reticular formations there. In the reticular formations, the fibers are also controlling, the pain fibers are also somewhat controlled by reticular formation in the brain stem. Here the these chemicals are opioids and receptors and tricyclic antidepressant. They act through this periaqueductal grey matter. Retrobulbar medulla and raphe nucleus, we have drug like serotonin and norepinephrine. They act through this retroventral medulla. Dorsolateral fasciculus to the dorsal GABA and glycine. So, you have some idea, some small idea about the neurotransmitters, because it is important for pain management. If you go for further studies, when you go to the specialties for pain management, this concept will help you. Now, this syringomelia, the different diseases are there. I will discuss these diseases later on if I get time. Sensory tracts we have learned. Now, you have learned the motor tracts. So, I have told you the descending tracts are pyramidal system and extrapyramidal systems. Why it is pyramid? Because there is a swelling in the medulla. Below that, there is a swelling anteriorly. It's called it's called pyramid. The corticospinal tracts. The corticospinal tract, that starts from the cortex. That passes from the coronal radiata, passes to the internal capsule, comes to the medulla. During that coming, they also supplies the cranial nerves, and then after that, at the lower end of the medulla, they cross to the opposite sides and goes to the pyramid. That is called pyramidal tract. But some descending fibers are not going through the pyramids. They are called extrapyramidal fibers. They are called extrapyramidal because they are motor fibers, but they are not passing through the pyramid. It's called extrapyramidal. What are the extrapyramidal system? They are descending motor tracts and do not travel through the pyramids of the medulla. They originate in the brainstem. I have told you the pyramidal tract, they originate from the cortex. Through the coronal radiata, they have compact in the internal capsule, they come. But this extrapyramidal tract, the nucleus is the higher center of the nucleus is at the brainstem. They are responsible for involuntary control and modulation of tone, power and balance. The corticospinal tracts are voluntary control. Corticospinal tract, there is difference between this pyramidal and extrapyramidal. Pyramidal tracts are corticospinal tracts. They are under our voluntary control, and we can have the actions at our will. But this extrapyramidal system, they are involuntary control. So, there are different tracts in the extrapyramidal system. There is rubrospinal tract, originates from the red nucleus. I have already shown you in the cross section of the spinal that there was a red nucleus. The red nucleus in the midbrain responsible for fine motor and contralateral innervations. Reticulospinal tract originates from the reticular formations. Reticular formation is in the brainstem, along the aqueduct. They are placed, diffuse reticular formations of the brainstem, and this reticular formation is responsible for your awareness. The reticular formation is responsible for their keeping our awareness. So, this is originates from reticular formation of the brainstem. Two components are pontine and medial reticulospinal tract. Originates from the pontine reticular formations. They facilitates extension. Extension is the anti-gravity muscle. The anti-gravity muscle, the extension, muscle tone, and helps in maintain posture. This contributes to the spasticity after stroke. You know, there is spasticity. No, there is a clasp knife rigidity. You have seen lead pipe rigidity. There are different types of rigidities. So this rigidity and spasticity, they are as we know the clasp knife rigidity. These are classical of corticospinal tract lesions. These anti-gravity muscle. Modular and medullary or lateral reticulospinal tract originates from the medullary reticular formation, inhibit extension tone and facilitates motor activity. Vestibulospinal, these all are important. Right? You have to facilitatory muscle, facilitatory fibers and inhibitory fibers also. That in coordination, a fine motor work will take place. So, vestibulospinal tract, they originates from the vestibular nuclei involved in balance and posture. Tactospinal and cerebral collicospinal originates from the superior colliculus, responsible for contralateral head and eye coordination. These are the descending motor tracts in extrapyramidal system. Now, you see the pyramidal system and extrapyramidal system. In the left side, you can read it. It is difficult to read. Anyway, I have already told you that side is not very clear. So, pyramidal tract lesions in the left side, the pyramidal tract, they have started from the cortex, they are come to the corona radiata, they are concentrated in this cortex, is the corona radiata, they are concentrated in internal capsule and comes downwards through the brain stem and medulla, then comes to the spinal cord, and in the medulla they will cross to the opposite side. But in extrapyramidal system, you know, there are different diffuse nucleus in the brain stem. Here it is a reticulospinal tract, red nucleus. This is a reticulospinal tract in the reticular formation. Vestibulospinal tract nucleus is here, and the tactospinal nucleus. These all extrapyramidal system comes to this, and this pyramidal system are there. So this, so pyramidal tract lesion is very important. To carefully read in the right side, pyramidal tract. They are lateral corticospinal tract and anterior corticospinal tract, corticobulbar tract. These three tracts constitutes the pyramidal tract. What the corticobulbar tracts do? Corticobulbar tracts, they also this part of the pyramidal tract. They started from the cortex, carries to the corona radiata, passes to the internal capsule, then they ends in the brainstem because they supplies the cranial nerves only. Cranial nerves. From there are several cranial, apart from the 1 and 2, all cranial nerves has to be supplied by this corticobulbar fibers, starting from 3rd to the 12th nerve. All fibers are supplied. All these cranial nerves are supplied, have motor supply. They have motor supply. If they have motor component, they will supply it from the corticospinal tract, for this corticobulbar tract, and all cranial nerves are really bilateral supply. So in corticospinal tract lesion, we don't see the internal capsule lesions. We don't see the cranial nerves are involved. But though the fibers are passing through the internal capsule, we don't see there are cranial nerves are involved because the cranial nerves has bilateral supply. Each cranial nerve nucleus is supplied from the left side as well as from the right side also. That's why they are not affected when the lesion is below the internal capsule or the internal capsule. Exceptions are there, like the upper half of the facial nerve nucleus. They do not have bilateral supply, and also the hypoglossal nerve, 12th nerve. They do not have bilateral supply. So there is a lesion in the one side, that nerve will paralyzed. Upper half of the facial nerve and except hypoglossal nerve, all this cranial nerve nucleus are supplied bilaterally. Anyway, the functions. What are the functions? I have already told you. Functions of the pyramidal tract. These are voluntary control, voluntary motor control, fine skilled movement. Fine skilled movement is buttoning and some movements are fine skilled movement, like buttoning and unbuttoning. Is a fine skilled movement. Okay, so these are fine skilled movements. Control of cranial nerves. I have already told you the motor nucleus of the cranial nerve. They are supplied by these corticobulbar fibers. The modulation of muscle tone and reflexes. Muscle tone, it is a partial contractile state of the muscle always remains ready for two actions. And reflexes, there are several reflexes. They are controlled by this pyramidal tract. If there is lesions in the pyramidal tract, what will be the feature? Very important. There will be motor weakness. There will be spasticity. I will know this typical is clasp knife rigidity. Is a typical clasp knife. Clasp knife is initially there is a spasm, then relax easily. Then again at the end of the action there is another spasm. That is called clasp knife. There is a movement of the knife. You open and folding knife. You open and close. The feel the resistance initially. Then it goes easily. Then at the end of the action, you feel some resistance. That is clasp knife rigidity. That is this typical of this pyramidal tract lesions. But extrapyramidal tract has lesions, rigidity, that is called what? Lead pipe rigidity. Lead pipe rigidity, you are folding a lead pipe. It will not have this initial later stage. The resistance will you will feel the resistance in throughout the actions, same as you have initiated and ended it. That is called lead pipe rigidity. This lead pipe rigidity is characteristic of extrapyramidal tract lesions. I have already described your extrapyramidal tract. So there are some differences clinically between these. So remember, this is clasp pipe rigidity and extrapyramidal tract, and this lead pipe rigidities there. So spasticity, hyperreflexia and clonus, because the reflex is a local act. Reflex is a local act. Knee jerk. If suppose you are seeing a knee jerk reflex, knee jerk, that is carried out by the L2 and L3 segment. That is a local action. The sensory fibers will carry from the, if you stretch the tendon of the quadriceps, the sensory fiber will carry the impulse to the sensory at the level of the L2 L3 spinal cord. Then L2 L3 spinal cord, the discharge will go to the anterior horn cell, and the L2 L3 quadriceps muscle supplied by L2 L3 that will contract. That is the whole fact in a knee jerk lesions. But this knee jerk lesion is also controlled by the corticospinal tract. Controlled by, particularly they are inhibited, so that the hyper reflex do not occur. If you put a knee jerk in the place, there will be some limited movement of the knee, because it is inhibited by the there is limited contraction of the quadriceps, because that is controlled by the corticospinal tract. But if the corticospinal tract control is gone, then that reflex, that contraction of the quadriceps will be vigorous, and we will see the increased knee jerk. Why this increased knee jerk? Knee jerk is controlled. It is a synaptic reflex there in the local level, but it is controlled by the inhibited by the corticospinal tract. But at the stroke, corticospinal tract is gone, that inhibition is gone, so there is hyperreflexia or hyper jerks. That's why we get a increased jerk in corticospinal tract lesion in stroke. All jerks are increased, in this way, because inhibition is gone. So that is called hyperreflexia. And clonus, and clonus is also the extreme projection of that hyperreflexia. Clonus, ankle clonus, how you see the ankle clonus? Just extend the ankle, and there will be continuous jerks. So there is ankle clonus, and there is extensor plantar response. That plantar response is extensor. These four features are pyramidal tract, very important for your examination purpose. And you can jolly well you can get a case of hemiplegia or paraplegia, where you will get this spastic paralysis, pyramidal tract lesions. There is a features are very important. You have to remember this all 4 points. There is what are the features? Motor weakness, spasticity, hyperreflexia, and clonus. These also are the features of upper motor neuron lesions, because we consider the corticospinal tract is the upper motor neuron. But if the lower motor neuron is the anterior, you know that what is the lower motor neuron is the anterior horn cell and onwards, and the peripheral nerve, anterior horn cell and onwards are lower motor lesions. But these features, 4 features will be absent in lower motor neuron lesions. Suppose the anterior horn cell lesions, the anterior horn cell is affected by motor neuron disease, or is the peripheral nerve lesions affected by peripheral neuropathy, or there is a disease called Guillain-Barré syndrome, where the posterior root is involved. Posterior root is involved. So all these things, the peripheral neuropathy, Guillain-Barré autoimmune neuropathy, or Guillain-Barré syndrome, or this anterior horn cell motor neuron disease, all are lower motor neuron disease. In that case, these 4 points, there will be motor weakness. Yes, there will be, because the anterior horn cell is gone, peripheral nerve is gone, motor weakness will be there. Spasticity is no spasticity. No spasticity will be there, because the nerve is gone, spasticity will not be there. Hyperreflexia, no, their reflex will be less, muted. clonus absent. Extracerebellar absent? No. So all of these last three features will be absent in lower motor neuron disease, but motor weakness will be there in lower motor and upper motor neural lesions. And in addition to that, in lower motor neural lesions, there will be wasting and fasciculation. We remember it. In the lower motor neural lesion, apart from these last two, there is no spasticity, flaccidity. It's a flaccid paralysis. Now, Guillain-Barré, what type of paralysis in a Guillain-Barré disease, Guillain-Barré syndrome? You will say it's a flaccid paralysis. So it is not spastic. These are the features of spastic paralysis. Flaccid paralysis, there will be motor weakness, but there will be no spasticity, no hyperreflexia, no plantar externus or plantar response. In place of that, they will have wasting of the muscle, more wasting. Upper motor neuron lesion is called disuse wasting. Disuse, because of they cannot use the limb. That's why there is some amount of wasting. Maybe there after some years, after a few years. But at the lower motor neuron lesion, the wasting probably from the very beginning. So wasting, and another is fasciculation. Fasciculation means there is a twitching of the muscles. You can see in your bare eyes the muscles are twitching. So this wasting and fasciculations, these are the unique features of lower motor neuron lesions, not upper motor neuron. Probably I have explained to you properly the differentiate the upper motor neuron lesions and lower motor neuron lesions. This is a very common catch questions asked in the exam. So these slides I have already shown you that the ascending tracts and lower descending tracts are there. Apart from this ascending and descending tracts, there is another system also that is controlling our voluntary movements. That is called basal ganglia. Apart from this pyramidal and extrapyramidal system, there are some lesions called. There are some areas which also controls our voluntary movement. There is basal ganglia. This is a group of deep brain nuclei. This helps to desired movement, inhibit unwanted movement, and stores motor program and learning. I have told you now the motor programs has to be stored and learning. If you have learned to swim, you can repeat it in your future activities. So they keep the memories of swimming. They keep the memory of cycling, like this. So this is done by the basal ganglia. What they do, they store the motor program. They know the swimming, how to do the swimming, what muscles has to be act in tandem and coordinated way so that you can swim. That is a learning. Learning is stored in the basal ganglia, and they also programming and learning and desired movement. So that the movement should not be exaggerated or should not be muted. It should be a desired movement. What are the component of basal ganglia? These are caudate nucleus, important for your short notes. Components of basal ganglia. This is the caudate nucleus, the putamen together. This is caudate nucleus and putamen together also called striatum. There is globus pallidus, substantia nigra, and subthalamic nucleus. All things have to remember because there are several diseases will come. Probably today I will not cover it. Next day we will cover the diseases associated with this today's learning. Very important class. The diseases associated with this. If you have the concept, go to your home and read it. Have the concept. Otherwise, you will not understand that this is the interesting manifestation of the different neurological diseases in our next class. Please go and read all these things and have a conception about this total system, pyramidal system, extrapyramidal system, and this basal ganglia. What are the pathways, how they act, then you will be able to understand the diseases associated with it. Very interesting class in our next class. So the components are there. So they act by direct pathway that stimulates and by indirect pathway that inhibits. So important, interesting. Now basal ganglia, I know that they have the coordinated movement. So they have to inhibit and as well as stimulate according to your will, according to their will. Basal ganglia, they can stimulate. They should have already to do the middle corticospinal and pyramidal and extrapyramidal. But this is very interesting was their coordinated activity. They can inhibit, they can stimulate also. So there is a direct pathway, indirect pathway is stimulatory pathway, and a direct pathway is a direct pathway and indirect pathway. Direct pathway is a stimulatory pathway, and by indirect pathway they inhibit. Since direct and indirect pathway is actually separate nerve fibers are there, but neurotransmitter is important. How they inhibit and how they stimulate at the same time. because this different by releasing different neurotransmitters. So I have already told you GABA is usually inhibitory, glutamate is usually stimulatory. The GABA amino butyric acid is usually a inhibitory. They always send a inhibitory signal to the postsynaptic space. You know, there is a stimulation in the synapse, the presynaptic stimulation, there is a release of the chemicals. In that way, the postsynaptic plate is stimulated or inhibited. So GABA, that inhibitory, glutamate is usually stimulatory, and dopamine may be stimulatory, may be inhibitory. The dopamine is the main neurotransmitter in substantia nigra. The main inhibitor is substantia nigra. And depending upon the type of the receptors, the diseases are Parkinsonism. We will discuss these diseases later on. But just Parkinsonism, there is loss of dopaminergic neurons in the substantia nigra. This is the main neurotransmitter, dopamine, that depletes in the substantia nigra, that causes Parkinsonism. So naturally, that if you want to relieve the Parkinsonism patients, if you want to relieve the symptoms, you have to give him what? Dopamine, because there is loss of dopamine in the substantia nigra. You have to give drugs which will supply dopamine to the neurons. Another disease is Huntington's chorea. This is an autosomal dominant disorder, and there is a cordate nucleus degenerations. You can MRI, you can see there is a cordate nucleus, the part of the basal ganglia. I have told you the cordate nucleus. That cordate nucleus atrophies. That is a there is disease called Huntington's chorea. This is autosomal dominant disorder. Hemiballismus, important disease that causes the excessive dopamine in the thalamic nucleus. You know that Parkinsonism, there is a loss of dopamine, but in hemiballismus, hemiballismus is a certain jerky movement of the one half of the body. Total one half of the body goes into a jerky movement, that sometimes the patient toss up from the bed, then they can lie down, because the whole half of the body, the muscle is going into jerky movements. So this is called hemiballismus. Very important for your MCQ purpose. Hemiballismus is due to excessive dopamine in the subthalamic nucleus. This is an important MCQ. In hemiballismus, which nucleus is affected? Which basal ganglia nucleus is affected? This is a subthalamic nucleus. And in Parkinsonism, it is usually the substantia nigra, right? And in Huntington's chorea is the cordate nucleus. Each three is important for your MCQ, multiple choice question purpose. So we end here today. In next class we will discuss the diseases. Just have a recapitulation of this. As a part of the recapitulation of this slide, there are the blue are the ascending fibers, spinothalamic tract, spinocerebellar tract, and the nucleus of the posterior column tract, nucleus gracilis, nucleus cuneatus, and the reds are descending tracts. They have anterior corticospinal tract, lateral corticospinal tract. There are extrapyramidal like lobrospinal, tractospinal tract. These are extrapyramidal tracts. Lesions are there, and in here it is here it is the anterior horn cell. It is anterior horn cell, and here is the posterior horn cell. The posterior horn cell, and here is the anterior horn cell. The corticospinal tract ends in this anterior horn cell, and after that, this is the posterior nerve root, and this is the anterior nerve root. Posterior nerve root carries the sensory fibers, and the anterior nerve root usually supplies from the anterior horn cell. This is carry the motor fibers and produce a peripheral nerve. There is a peripheral nerve is produced.